Hello, everyone. Welcome to our PNA New York 2020 virtual series. This would be our second to the last educational session under the leadership of our current president, Dr. Marie Orteliz. It was a real pleasure and a privilege to serve under her leadership, who elevated our organization and profession forward to continue to promote health. Hence the theme, reimagine and transcend the culture of nursing, advocating current trends in practice, incorporates nursing science and practice into transforming nurses as leaders and advanced clinicians for the purpose of advocating for safe and quality patient care. Subject matter experts share their knowledge and skills on relevant selected topics that enlighten and nurses on current trends that will promote caring practices and serve to enrich the nursing profession. Before I introduce our president, we have a few housekeeping rules. Davey, our vice president, who's also in charge of our webinar, will mute everyone until the presentation is over. We will have a Q&A portion, and you can enter your question into the chat box, and Davey will read it out to our speaker. You will also get a survey, that's a program evaluation, and once you fill that out, you could get your contact hour certificate. I would like to introduce our president now, Dr. Marie Orteliz.
Thank you, Jonah. Good evening, PNA New York members and attendees. Welcome to the second series of the PNA New York Education Forum. Education forums are presented in the fulfillment of the organization's mission in advancing nursing knowledge while promoting the image of nurses in the state of New York. The second series will inform us of relevant issues in healthcare, the care of cancer patients in the midst of COVID-19 pandemic. We did not know much about COVID-19 6 months ago, but thanks to the information gained from scientists and researchers who have been closely monitoring the disease and providing us with information, we now know more about it. Our knowledge base about this disease have also been augmented by nurses and doctors who can attest to what works and what doesn't in the context of treatment as they continue to care for patients afflicted with the disease. Let us welcome Rex Lomboy, who will provide us with more information in his area of specialty. His information will be very useful to us as healthcare practitioners and educators. Thank you.
So Rex will have no financial interest or affiliation concerning material discussed in this presentation. Will not discuss any non-FDA approved or investigational drugs or medical devices. This presentation will be for information and education only and not to provide medical advice. Rex Daniel Lomboy is the Associate Director of Nursing at Mount Sinai Hospital Oncology Tumor Service Line in New York City. Before moving to New York City in 2017, he has been in leadership roles at different hospitals in Houston, Texas. Rex received his Bachelor of Science in Nursing, summa cum laude, and his Master's in Business Administration and Healthcare Management from the University of Texas, where he was also inducted into Phi Kappa Phi and Beta Gamma Sigma International, respectively. He serves as a board of director and advisor to some of the different prestigious professional organizations he is affiliated with. Rex is also currently pursuing his doctorate in nursing practice, which is so impressive. This is in healthcare leadership systems and policy degree at Yale University. We could go on and on. He's got a very impressive resume and experience, but with the interest of time, we have to give him away to you. Welcome, Rex.
Thank you. Good evening, everyone. I'd like to take this opportunity to thank the Philippine Nurses Association of New York for providing me the platform to share insights about some of the best practices about COVID-19, specifically in the ambulatory oncology setting. Before we begin, please note of this copyright notice. In the next 30 minutes, I'd like to share insights about the measures to promote patient and staff safety in the hospital. Likewise, I'd like to discuss the learning opportunities that my team experienced and that we can leverage to remain prepared. And lastly, I'd like to highlight one of the most important topics that is underreported or lacks acknowledgement, but affects all of us in monumental ways, whether directly or indirectly, and that is mental health and how to remain resilient during these challenging and unprecedented times. Before I dive into the lecture, I'd like to have an understanding of my audience and determine the roles and responsibilities each of you hold. You can either take a photo and follow the link of this QR code or manually visit your website or browser rather, and enter the code 80913. I'll give you a minute to respond. I think majority is in the administration, clinician, okay. All right, so majorities in the leadership position, and we have some clinicians and a student as well. All right, so for the first topic, and it's focused on measures in promoting safety, not just for patients, but also for the staff members. All of us can agree that ensuring the safety and health of our patients is as important and critical as ensuring the safety of the doctors, nurses, and staff members. And the first step is clear communication. As new information or update becomes available, leaders are expected to promote transparency and collaboration to the staff via multiple platforms. As a high reliability organization, preoccupation with failure, such as contingency planning, and sensitivity to operations like tiered huddles are crucial to maintaining safe and effective operations. Out of all the methods of communication, visibility, rounding, and huddles, in my opinion, are the most important platforms that have worked during the crisis, as it provides a collaborative discussion between a speaker and audience. Emails are great, but staff can be alert fatigued by the end of the day and will likely not able to retain the information. And it's okay to say, I don't have the information to that, but I will circle back with you once the information becomes available. Being honest and truthful to say we are working on ways to get the answer that you need is absolutely better than no huddles, no rounding, no visibility at all. Town hall meetings serve as platform for general items such as PPE updates, employee resources, protocols, patient screenings, and many more. Newsletters and website contain the information to be able to access the latest information needed or retrieve the archived information for comparison and learning. Again, communicate, communicate, communicate. It is truly, truly remarkable. Moving on to PPE, personal protective equipment continues to be an important topic in maintaining safety in patient care delivery. The current guidelines is for all inpatient and ambulatory healthcare workers to wear eye protection in addition to the surgical mask when having a direct patient contact. Universal mask is considered surgical mask. Full PPE consists of N95 mask, gown, gloves, face shield, or goggles. And the full PPE, we only wear them during when performing aerosol-producing procedures in exam or procedure rooms. And this is just for organizations that don't have sophisticated tool to track the PPE. There is a tracker app created by the National Institute for Occupational Safety and Health that facilities can use to track PPE use, calculate consumption rate, burn rate, etc. Moving on to testing. Testing and screening has been an iterative process as we take into consideration the latest guidelines from the CDC, New York State, and research studies. COVID-19 PCR testing and COVID-19 antibody testing are made available and accessible to employees and patients. For employees get tested based on whether they are symptomatic or asymptomatic. We utilize the Red Cap as a platform for employees to submit their requests for testing, and once the information is entered, employee health clinician will contact employee about next steps, whether they need COVID testing, or they need to be evaluated by the doctor or an emergency room, or whether they can return to work. On the other hand, patients are required to obtain COVID testing prior to the day one or the first day of any cycle of their chemotherapy. Exceptions can be made on select patients, of course, and a treating clinician always reserves the right to test or not to test the patient prior to chemo infusion. For non-chemo infusion, we have categorized infusion medications such as high risk, unknown risk, or low risk. Only the high risk medications require COVID testing prior to administration. The remainder is at the discretion of the treating clinician. Some of the high risk medications include cyclophosphamide, ocrelizumab, rituximab, and methotrexate. Moving on to screening. As we are a disease-based group, each practice completes and performs their phone screening 24 to 48 hours prior to the actual visit. The components include infectious disease screening tool, COVID symptoms, COVID result if tested outside of the facility, and visitor policy reinforcement, and COVID testing appointments if applicable. This phone screening process was initially centralized when we had the luxury of having employees who had to work from home, but have since been decentralized and shifted the responsibility to individual practices. I would say that this has been one of our successful initiatives as patients receive a call from a live person that can answer questions or escalate them accordingly to their practice. I recall from March 2020 up through mid-July, there were over 16,000 calls made with 50% capture and 5 to 8% escalation. Capture meaning they have reached the actual patient, and escalation meaning they have had to address patient concerns and escalate them to the treating clinicians. Speaking of capture and escalations, if a patient happened to screen positive or considered as PUI or person under investigation, there are various pathways the doctor can decide for the patient to take. So first, doctor is notified and the patient can go to telemedicine or be rescheduled for a later in-person visit, sent to the emergency room, or even allowed to visit the site, but through a coordinated fashion, meaning they arrive in time or they arrive at a specified time, and we escort them directly to the private designated infusion area where they can receive the non-chemo treatment and assessment while limiting exposure to other patients. Meanwhile, the lobby screening has a similar structure and objectives with the phone screening, except we verify their temperatures using touchless thermometers and verify the COVID testing results upon arrival and prior to proceeding with the visit. Phone screening, if you will, is like the first layer, and the lobby screening is our second layer. Technology used in lean methodology have been remarkable in promoting efficiency in this process. One key aspect that we also tried and has tremendously worked is assigning a clinical leader, an RN, as a resource person and point of escalation. Additionally, we have utilized the airline system. So think check-in, tagging your bags, dropping your bags off upon check-in, where patients line up for their visit and appointment they have. And just like, again, the airline system, there's a customer service kiosk where the clinical leader sits to address any issues and concerns. Effective process require documentation, and when you document well, it allows for quick updates based on the changing circumstances and easier communication across the staff. Here's an example of the process map we have developed to ensure that information is streamlined across the continuum. This is another guide I created myself for the team that identifies the various scenarios patient could fall into contingent upon their COVID status, symptoms, and patient needs. Based on that, patient proceeds with normal visit or are isolated accordingly. This is the photo of our phase 1 lobby screening process using the airline system check-in process. And of course, as things return to normalcy and the return to practice phase has started, the need to expand the screening procedure came about. This phase 2 involved a wider reach and surge planning for high traffic times. This expansion doubled the amount of patients that can be accommodated to be screened from only 8 patients to 16 patients at any given time. Moving on to social distancing. Social distancing and visitor policy are important measures to prevent exposure. There's certainly challenges in hardwiring the initiatives, but continuous reminders via huddles, broadcasts, signages, and decals, and pod quarterbacks, as we call it, or the police, which we recently implemented to promote reinforcement. Restrictions apply on the amount of individuals in the elevators and waiting rooms. Meeting rooms remain to be limited to 10 people or less. Otherwise, it is held in Zoom, just like when we are now. Lastly, visitor policy in the ambulatory oncology side continues to be restricted to new patient and their first visit, and returning patients with cognitive impairment under the age of 18 and any patients that require end-of-life care discussions. Beyond those scenarios, visitors are expected to wait in our socially distant lobby chairs. On rare occasions, visitors are allowed to escort patients to the treatment rooms and office visits, but must return to the lobby and will be notified via call or even FaceTime if needed. Environmental services continues to play a tremendous role in ensuring safety of our staff and patients. Increased disinfection rate have certainly been instituted in our daily practices. This list contains the standard products for disinfection and appropriate alternatives. Again, it's a summary for the first objective, that is measures to promote patient safety and staff safety, communication, visibility, technology use, and engaging of frontline teams have been the pillars to our continued success. Moving on to the second objective, leveraging the learning opportunities. And this remains to be an iterative process, and I strongly encourage everyone to remain vigilant in obtaining the most updated information. Preparation is the key. Know where to turn for reliable and up-to-date information in your local community. Monitor the CDC COVID-19 website and your state, local department for the latest information. Develop or review your facility's emergency plan. We can all agree that staff absenteeism is one of the results of COVID-19 outbreak. Preparing for alternative staffing plans to ensure as many of your facility staffs are available should be at the top of your list. We had a centralized system of tracking the amount of nurses, nurse practitioners, doctors, and other non-clinicians so we can effectively plan for staff redeployment, staff coverage, and etc. Know about public health emergency planning and response activities in your community. Learn about plans to manage patients, accept transfers, and share supplies. Review any memoranda of understanding with affiliates, your local health coalition, and other partners to provide support or assistance during emergencies. Develop and continuously update emergency contact lists for key partners and ensure the lists are accessible in key locations in your facility. Speaking of key locations and repository, communication and accessibility to the information for retrieval are important considerations to make. We become fatigued with information, so it is essential to have a repository to be able to access the most updated information on screening, testing, travel and PTO policy, employee health information, PPEs, etc. I know this goes back to screening, but as an example of an important information or policy that needs to be communicated and updated regularly with the staff and patient includes the high-risk states identification. For patients who traveled internationally or from high-risk states, our goal is to move the patient visit after the 14-day quarantine. If the appointment cannot be moved, patients with recent travels from the high-risk states or international locations are automatically screened as PUI, person under investigation, inclusive of a negative testing within 14 days of arrival to New York State. The same rules apply to employees. Employees are required to quarantine using their own vacation time should they choose to travel internationally or to the high-risk states. Exceptions can be made, of course, to the employees, but on a case-by-case basis and after confirmatory PCR testing. This goes hand in hand with the communication. We can all agree that we need to protect our workforce, otherwise we will not have the capability to take care of our patients. Measures to ensure the safety of our teams include patient and personnel screening, PPE management and employee health guidelines for symptomatic employees, and healthcare personnel who come in close contact with confirmed or possible patients with COVID-19 should wear the appropriate PPE. Personnel who develop fever, respiratory symptoms, or other symptoms should be instructed not to report to work. And ensure that your sick leave policies are flexible and consistent with public health guidance and that employees are aware of these policies. And finally, protect your patients. In oncology, our patients are some of the most vulnerable populations. So how do we achieve that? Separate patients with fever, respiratory symptoms, or other symptoms so they're not waiting among the other patients seeking care. Identify a separate, well-ventilated space that allows waiting patients and visitors to be separated. Consider strategies to prevent patients who can be cared for at home from coming to your facility, potentially exposing themselves or other people. Using your telephone system to deliver messages to incoming callers about when to seek medical care at your facility, when to seek emergency care, and where to go for information about caring for a COVID person at home. Adjusting your hours of operation to include telephone triage and follow-up patients during community outbreak. And lastly, leveraging your telemedicine technologies and self-assessment tools. Before I dive into our final objective, I want to acknowledge that COVID-19 has brought significant and staggering impact on our lives and the lives of those around us. Less visible, but no less real, is the other well-known consequence of a pandemic, and that is the psychological effects on our internal worlds and outward behaviors. I want to say that mental health is real, and that during this time of crisis, I would like to encourage each of you to take advantage of the many mental health resources available to you. Just like we need to take extra precautions to protect ourselves from being infected by COVID-19, we also need to be aware of the psychological risks we healthcare workers are facing. There's so much information to discuss about mental health awareness, and especially the effects of COVID-19. But in the interest of time, I will highlight the most important topics and provide you with the resources that you can later read upon. Starting with misconceptions. There are a variety of misconceptions which might stop individuals who could potentially benefit the most from seeking mental health care. I really want to emphasize this. We are at the greatest risk for psychological risk simply by virtue of our exposure to the reality of COVID-19. And that is why it is important to understand and overcome these mental health conceptions. Getting mental health care is evidence that I'm crazy. It's not true. I'm not ill enough to get mental health care. I don't have the time to get care. Does this mean that I have to be in mental health care forever? I'm concerned that my employer will find out that I'm getting mental health care. Please take a moment to ponder if these misconceptions apply to you. And if they do, I'm afraid you're wrong. And I encourage you to listen closely in the succeeding slides. Experts in disaster mental health have reached a consensus on 5 broad strategies for promoting mental health in ourselves and our coworkers during events like COVID-19. The 5 core strategies include promote a sense of safety, promoting calm thinking, promoting a sense of empowerment, connectedness, and hope. I put this slide from Stormont Vail Health that talks about the mental health and not knowing the resources to take advantage of. Someone who seeks professional therapists or counseling is practicing self-care and resilience. If we have the workout routines like going to the gym for our physical body to maintain physical and physiological health, we should also strive to care for our minds. And I'm not ashamed to say that I seek professional counseling just to be able to express my challenges and frustrations, not only in my personal, my career, but also my academic environment, to someone who will not judge me and is professionally trained to be able to redirect me in finding a better and brighter perspective. Yes, I agree that finding time remains a challenge for me, but I strive my hardest to commit to those sessions because I always feel renewed after each session, especially during the height of COVID. I'm sure the audience can appreciate this photo as it clearly depicts the resilience of the Filipino people during the height of Typhoon Haiyan, or Yolanda. Resilience, by definition, is defined as stability in the face of adversity or bending, but not breaking. Dr. Dennis S. Charney, the Dean of the Icahn School of Medicine at Mount Sinai, shared the following established behaviors that promote resilience and can help us get through traumatic events and even grow from them. These are engaging in realistic optimism, facing your fears, knowing and living by your moral compass, turning to your faith and spirituality, establishing and nurturing a supportive social network, finding resilience role models, attending to your physical well-being, and that is also exercise, good diet, and good sleep hygiene. Develop brain fitness, apply cognitive and emotional flexibility to trauma and other challenges, and finding meaning and purpose in things. Alongside resilience is an important topic about self-care. In another approach to psychological protection, the Center for Traumatic Stress Studies of the Uniformed Service University recommends the following for healthcare workers. Meet your basic needs, take breaks, and actually be on break. I'm guilty of this sometimes because of the workload, but it's often counterproductive to multitask and taking your lunch and your work at the same time. Connect with colleagues and being present with your colleagues. Communicate constructively with colleagues and contact and connect with your family. I must say that this is one of the silver linings of COVID because my family and I have been closer than ever. We have this Facebook Messenger call every single day during the COVID and has continued even up to this day. Respect differences in how much others want to talk and stay updated with the information about COVID-19. But there's a caveat: limit your exposure to the media. Do self-check-ins, and most importantly, honor your service. The last part of my webinar talks about the resources to mental health and psychosocial support. Within the Mount Sinai Health System, the following resources are available for all the staff and students. The Wellbeing website serves as the main hub for all the mental health needs. For crisis support, employees, students, and trainees can call Crisis Line to connect with 24/7 mental health crisis response teams, staffed by mental health professionals from the Department of Psychiatry and the Department of Social Work. Leaders can even call the crisis support line for urgent group crisis support sessions. There's also availability for one-to-one support via outpatient telepsych, employee assistance programs, and Mount Sinai Calm. Mount Sinai Calm connects you to the experienced and compassionate licensed social workers. And based on your conversation, you will receive a holistic personal care plan and set of resources that support your overall health. One of my favorites actually is the Chi Time, which fosters a safe and quiet environment to just be. Participants like myself are offered guided meditations, breathing exercises, and centering reflections, and we get these amazing teas and kind bars. Sometimes just those few minutes can make a huge difference in how the rest of your day will shape up. And just really finding the time to take a break and leaving your desk, going to the park for lunch, or anything that takes your mind off can be extremely beneficial for your mental health. Additional external resources are also available, and I've compiled a few specifically for the residents living in the tri-state areas. New York City Well is your connection to free, confidential mental health support. You can speak to a counselor via phone, text, or chat and get access to mental health and substance abuse services in more than 200 languages, 24/7, 365. The National Suicide Prevention Lifeline is a national network of local crisis centers that provide free and confidential emotional support 24/7 to people in suicidal crisis or emotional distress. Octave is a modern behavioral healthcare practice with over 15 psychologists and counselors who specialize in a wide range of topics, including anxiety, trauma, depression, and even couples therapy. New York City COVID Care Network is a volunteer network of support for essential workers, their families, and any uninsured New Yorkers. The Integrative Trauma Program at the National Institute for the Psychotherapist offers 3 free therapy sessions to any healthcare worker who would like some support with resourcing, coping, or processing disturbing images. Clinicians are all licensed social worker or PhD trained to provide crisis intervention. In partnership with the Kate Spade New York Foundation, New Yorkers can access a 24/7 emotional support service for frontline healthcare workers. There's also apps available at the touch of your fingertips. COVID Coach app can be downloaded from the App Store on any phone. This app was designed by the Department of Veterans Affairs and offers resources, emotional support, tips for self-care and stress management for anyone during the COVID-19 pandemic. And finally, the Headspace app. I'm sure you've seen ads in subways about Michael Phelps promoting the app. PsychHub contains the links to a myriad of resources for the most credible mental health organizations in addressing mental health needs, specifically for COVID-19. And one of the resources is from Harvard Med with links to the webinars that talks about the role of anxiety, slowing down the brain, charging up and staying connected, and exploring thoughts, which I know we can all benefit from. Video number 1 talks about the role of anxiety and focus on how to assess the level of our anxiety. And then we can apply some of the concepts of CBT or cognitive behavioral therapy to a particular stressor that many people in our community are experiencing, such as adapting to the ever-changing timeline of how long we'll need to be in social distancing and isolation. Video number 2, slowing down the brain, is focused on skills for reducing the flow of anxious thoughts, particularly as we consume massive amounts of frightening information about the COVID-19 crisis. Video number 3, charging up and staying connected, highlights the sense of loss that many of us are experiencing right now as a result of social distancing and how activating our brains and bodies can help us manage those emotions. And lastly, video number 4, exploring thoughts, is focused on how to interrogate the catastrophic thoughts that many of us are having right now and offer specific tips for parents who are looking for strategies to help support the emotional health of their children during the crisis. In closing, I'd like to end with a note of reflection and some perspective. We all have lost friends, families, colleagues, and these are extraordinarily difficult times. What we're going through is a stark reminder that caring for our patient requires that we also take care of each other. As many of you know, St. Catherine of Siena is a patron saint of nursing. She earned that moniker during the Black Death in the 1300s, fearlessly caring for the plague victims while losing most of her family to the disease. Listen to her words. Nothing great is ever achieved without much enduring. I carry on in part to honor my friend and colleague, an incredible nurse, warrior, and exceptional leader, Kaius Jordan Kelly. He was an extraordinary soul who never skipped a beat in uplifting others. May all of us continue doing just that every single day. Thank you for your service, and thank you for joining me this evening.
Thank you very much, Rex. Now we have the Q&A portion of the webinar. We have a question from Ms. Lizelle Vince Cruz, our corresponding secretary, PNA New York. Lizelle?
Lizelle, I unmuted you so you can speak. Just unmute yourself. Go ahead, Lizelle.
Oh, hi. Sorry about that. Good evening, everybody. Good evening, Mr. Lomboy. Thank you for that very informative lecture. I actually have 2 questions for you. First one, have you seen any different clinical presentation of COVID-19 in patients with malignancy? And the second one would be, what do you think is the most serious impact of COVID-19 on cancer patients and their caregivers?
Okay, so the first question is any different clinical presentation for patients with COVID-19 with malignancy, right? There are literature that discuss and suggests that patients with cancer care are more likely to contract COVID-19 and are at higher risk for significant morbidity and mortality with COVID-19 infection. Additionally, COVID-19 associated symptoms can be difficult to differentiate from symptoms of cancer and cancer treatment, hence making the care delivery more difficult. Lastly, at Mount Sinai Hospital, majority of the patients that we have remains to have the same clinical syndrome, right? But one significant difference, however, is that patients with malignancy and the ones that have contracted COVID-19 seems to remain COVID-19 positive for a very, very long time, even after their illness has resolved. I think the second question is about the impact. Is that correct?
Yes. What's the most serious impact on cancer patients and caregivers of COVID-19?
I would say 100% delay in cancer care, unfortunately. We know that the outcomes in cancer care is critically dependent on the chemotherapy and the timeliness of the therapy. And we have witnessed a lot of delays in the need for care during the COVID-19 pandemic. Delays in treatment and diagnoses can lead, as we know, to increased staging, increased morbidity, and unfortunately, we have lost some of our patients to COVID-19.
All right, that's good. Thank you, Rex. We have another question from Dr. Priscilla Segar. She's one of our board of director, PNA New York. Dr. Segar, are you on?
Okay. Oh, hello. I wanted to compliment you, Mr. Lomboy, on your very comprehensive presentation. And from your presentation also, there are so much resources where you work. But I will ask my question anyway. What were the most challenging aspects of cancer care did you encounter during the pandemic? And what did you do? What strategies did you use to, to solve them?
That is a very good question. I could probably do another webinar just to discuss them. Not just in oncology ambulatory care, but the entire health systems operation, including inpatient, had to make a lot of logistical changes in terms of office visits, treatments, infusion, and even research protocols had to be deferred. We face a lot of pushbacks from our patients or visitors because of our visitor restrictions. We even had to cancel or reschedule a number of our visits and shift our staffing resources to the inpatient. So in fact, we redeployed a lot of our members. And I remember dealing with the redeployment, and I think we redeployed about 100 staff members in outpatient to various areas in the hospital. We also created an inpatient surge unit, if you will, in an ambulatory space, converting that within 5 days. And they're strictly for the non-COVID oncology patients that required admission. We have, again, restricted visitors from going to the treatments and office visits. So we use technology such as FaceTime or call to bridge the face-to-face gap. Again, I can go on, but overall the challenges that we have faced and continue to face have been addressed and mitigated through open communication, effective collaboration, and resilience. And we've been very fortunate to have a wonderful medical director and chief quality officer who's always present and eager to answer any of our questions. And I think that's really the wonderful key is for the treatment, the triad. You have your nursing leader, you have your admin leader, and you have your medical director leader in engaging and making sure that we address issues in real time. I hope that answers your question.
Yes, yes. Thank you.
Thank you.
Any
Um,
other? Go ahead.
Warley has a Remeo as a question. I'm going to unmute you, Warley. If you could unmute yourself, go ahead. Please ask your question.
Great, great. First of all, thank you so much, Rex. This is a very informative presentation, and it's quite relevant, especially as we continue to face this pandemic, not just here in the tri-state, but the other parts of the country. So my question to you is that we all know that the oncologic patients, our cancer patients, are highly vulnerable with infectious disease, and so with COVID. Were there any specific strategies that you put in place to protect the inpatient cancer patients, and also with your outpatient cancer patients? And you've mentioned about mental health, and I know that they're very prone or very vulnerable with psychiatric or psychological issues as well. So is there any programs that you put in place for them?
Absolutely. I think I'll answer the first one first, your first question first, and that's like the infectious disease methods or preventative methods for our patients. Apart from the social distancing and masking and making sure that we protect our patients, we really leverage the telehealth medicine to make sure that they don't have to come into the hospital unless absolutely necessary. But there's a caveat to that, and they can't really be seen, and we defer their treatments. But overall, I think that was the best way for us to be able to prevent them from getting exposed to COVID-19, and it has worked drastically. In fact, we are piloting this new paramedicine wherein the paramedics or the ambulance system are going to the patients' homes for testing, for COVID testing, prior to their chemotherapy visits. And that's in an infancy stage. We're actually going to go live in 2 weeks, I believe. But that's another way for us to be able to prevent them from really coming into the site and just getting their treatments or getting their assessments or visits virtually. However, if they do have to come into our practices or into our sites, we have to make sure that we're screening them appropriately, and that's why we've implemented the phone screening and the lobby screening process to make sure that we capture every single patient that needs to be isolated, and that's that has really tremendously worked in the past in identifying and understanding the measures to be able to treat and mitigate those once they have been identified. A lot of staff communication, a lot of logistical planning, a lot of huddles, a lot of collaboration, a lot of emails. And like what I said, we become email fatigued. And lately I've been piloting the Microsoft Teams as a platform so I can communicate to the staff in real time what the information is. We're inundated with a lot of emails, and I want to leverage another platform that can easily be retrieved and be notified via push notification. With regards to the mental health question and mental health resources for our patients, we have a very robust program for that, and we do a lot. We do connect and partner with our social work department to make sure that they provide those resources. Just as I have provided you the resources for mental health, those are also accessible to our patients. And in another, and make sure that we do follow up with them also. And part of our screening process and part of our visit is making sure that they are okay, not just physically, but also emotionally and mentally. I hope that answers your question.
Correct.
We have a question. Janet Kwaikong raised her hand. Go ahead, Janet.
Hi, Rex. Thank you, and congratulations again. It was a beautiful presentation. Thank you for paying tribute to our good friend, Caius. And coping with pandemic and the mental health. I know personally, I don't have time to go see a therapist. I know I need one.
a lot of us really need one, and just for our own to cope. But what do you suggest? Simple tips just to help us cope with and live with this pandemic, and through this, especially we have own personal losses.
That's a very good question. I was in your shoe as well. I could say that I didn't really have time, nor did I want to find time to be able to see a therapist. So first, I really want to plug the therapist. And for us in Mount Sinai, we have the opportunity to be able to leverage those resources that we have for free. I mean, you don't even have to pay for it, and you can just talk to someone confidentially, right? If you don't have the time, again, I suggest you find time. I'm kidding. But if you don't have the time, I think just finding what really makes you happy, and whether that's cooking, whether that's grocery shopping, and what has worked for me is just cooking or grocery shopping. In fact, those have been my outlet during this COVID time. I mean, we couldn't go anywhere except for the grocery stores or liquor stores, but we're not going to go there. Grocery shopping and you know, and cooking have been my sort of my, I don't know, outlet, if you will, in just trying to cope with this pandemic, and even beyond that, you know, making sure that you connect with your friends, making sure that you connect with your coworkers. Know that you're not the only person living this, and you should remember that. You should remember that you're not, and it's okay to feel okay. It's okay to say, I don't feel okay. You're not supposed to be you know, the superwoman or superman to your staff members. You can cry, you can be vulnerable in front of them. I have. I'm not ashamed to say that, because it pays a tribute to be a human being. And based on that, you can find such blessing, or you can just find such relief in knowing that someone supports you, or there are other people like you that feels the same way, and they can then give you that, you know, moral support and confidence boost. Yeah, I can go on and on with this thing, but I'd leave it to making sure that you find your outlet and really seeking a therapist. It's amazing how much impact, or how much benefits you can reap from just talking to someone and just expressing to someone.
Great. Thank you, Rex. Jonah Caparas, our moderator, has a question for you.
Yes,
Go ahead, Jonah.
Yes, I guess I could ask the question. Have you seen any increase or difference in mortality rates for those who are the cancer patients with COVID than those who are not affected by it? The mortality rates.
Just to paraphrase the question,
Okay.
have I seen mortality rates with cancer with COVID and cancer with non-COVID, right? I don't have the latest statistics with me, but having just speaking to the Chief Quality Officer, Dr. Smith, we've seen an increase with COVID-19 patients who have not been treated with, you know, have been deferred because of care, because of delay in care. I would say that, you know, COVID-19 has tremendously impacted the type of treatment that these patients have. So it's really one of those things where you have to equate, or where you have to weigh in whether you have to bring them to the hospital and be exposed, or you have to just keep them at home and not receive their treatment. But to answer your question, I'm not sure what the actual rate is, but we have seen a dramatic increase in deaths of patients, or even progression of the disease for those who have not been treated in a hospital and not have had COVID.
Thank you.
Great, thank you. We have a question that came into our Q&A box. It's from Susan Gador. She says, thank you for the excellent and informative presentation. Mr. Lomboy. Her question is, how do you manage your other ambulatory patients, especially those who have traveled out of New York on or before the COVID-19 crisis into New York State and now may be hesitant to travel back to New York for fear of being already immunocompromised and fear that they may catch the disease during their travel?
It's a very good question. I mean, as a large, oncology center in the United States, and we have the most robust multiple myeloma program, a lot of our patients are from out of state. And we try to connect with them using telehealth medicine, and we try to, as much as possible, provide the care virtually. But for those who need the infusion center, we have leveraged, the phone screening process, the lobby screening process, and really the education to allay their fears and to let them know that you are safe to return to our site, and that we have equipped ourselves and our facility with, with the cleaning resources, with social distancing, with masking, and all our protocols that we've instituted to make sure that our patients are safe. I think a lot to do is communication, and a lot to do of our mitigation have been relative to education, just to connecting with them and letting them know that we have the resources, and reassure them that it's okay to come in when they absolutely need to. With the new guidelines for patients who have traveled from out of state, we do allow them to come in, but we just need to identify them ahead of time so we can make the appropriate measures and appropriate place to place them. And we have identified multiple isolation rooms in our facility to make sure that they go in, they get treated, they go out, and we do a high touch cleaning for those areas. Unless, of course, they had an aerosol producing procedure, which would require a terminal cleaning. I hope that answers your question.
Great, thank you. I have a follow-up question that Wally Remejo would like to ask. Go ahead, Wally, you can unmute yourself.
Oh no, Davey, sorry. I think that was by accident. That's all right.
Oh, okay.
Thank you.
Welcome. If you have any questions that you'd like to ask Mr. Lomboy, please type it in the Q&A. Or if you prefer to ask him the question live, just please raise your hand and I'll acknowledge you and I'll unmute you. Currently, Jonah, there isn't any questions on the Q&A chat or anyone's raised their hand.
Oh, I have one last question for you. Prior to COVID, how many patients do you see a day over there or per year at the oncology outpatient unit, and compared to, now after COVID? Well, actually, it's come down now, but
That's
how
a good
many
question.
patients were there? Yes, yeah. Go ahead.
So our usual volume pre-COVID volume visits would range from 1,200 to 1,300 every day. And it's a huge operation because we have the infusion suite, we have office practice visits, we have the radiation oncology, and we have the Dubin Breast Center that encompasses those visits. During COVID, that has significantly reduced. I would say we have shifted a lot of telehealth medicines, and it was reduced by half for the in-person visits. We are starting to ramp back up. Our return to practice phase has officially commenced, I believe, July, and we're seeing the numbers back again. Today's census was about 1,050. So it's coming back, which is a good thing for us, which is a good sign, not only financially, but just like seeing some sort of normalcy into the scene, seeing our patients back again, and of course dealing with the visitor restrictions and getting pushbacks from patients and whatnot. But essentially, overall, the feeling is great. Seeing the return to normalcy and return of volume back to pre-COVID numbers.
Great. Thank you, Rex. We have a question from Marie Ortiz. Marie, would you like to ask your question?
Yes. Hi, Rex. Thank you so much for your presentation. It was a wonderful one. My question is, it might have been answered, I'm not sure. The question is, since cancer patients are immunocompromised and at risk for any other type of infection, how does a caregiver decipher whether the symptoms the patient is presenting is any other infection or is it COVID-19?
That's a very good question. I think it has a lot to do with knowing the patient's history and the patient's background. A lot of our patients have been pre-existing patients, so they could very well have the cough for over 2 years, and that's just their baseline. Or they have shortness of breath at baseline. So just differentiating that and knowing that each provider has an intimate relationship with their patients provides a good structure in differentiating whether it's a COVID symptom or not. We've had those instances where patient presented with fever or with shortness of breath and cough, but they have lung cancer and their baseline short of breath and have chronic cough. So we've had our lobby screeners would have to notify the physicians, and the physicians would then say, patient's okay to come off and this and that. I mean, we have a very intricate process in making sure that none of the patients with symptoms would actually go up to their visits and proceed with their visits. And that's how serious we are in making sure that the spread of the disease doesn't happen in our setting, and it's prevented at the very doorstep of our facility.
I see. Thank you.
Pleasure.
Jonah, I don't see any questions in the Q&A box, nor any hands raised. Jonah, you may have to unmute yourself.
Again, I want to thank everyone for joining us, and Rex for a wonderful and very informative presentation. I hope everyone enjoyed it. I certainly did. I was an oncology nurse at Sloan Kettering for many years, also at Westchester Medical Center. So, you know, it's a different type of nursing. You really get exhausted, and it really drains your spirit sometimes. And I can imagine how you feel and your nurses feel especially during COVID time, because you lose a lot of patients and you're attached to the family until the end, you know. Thank you. So, Davey, would you like to announce the next event that we have? We will also have our next and last series, number 3, on August 27th, promoting culturally and linguistically congruent care at your workplace, to be presented by Dr. Priscilla Sager, one of our BOD, who also asked a question tonight. Davey, you have anything to add? And Marie?
After Davey.
Just to remind all our PNA members who are active that we have our General Assembly this Saturday from 10 to 12. Please check your email for the information related to the Zoom meeting link. Thank you. And yes.
All right.
And then
so thank you, Rex, for the information you shared with us tonight. Thank you, viewers, for your participation. Stay tuned to the next series scheduled for August 27, as mentioned by Davey and Jonah. It's always a pleasure to interact with you while keeping an open mind in our discussions. We will make a difference in the care of patients and advocate for the good health of the general public and ourselves as we learn more about COVID-19. So good night, everyone. Stay well and be safe.
Thank you, Rex. Thank you, everyone. Good job.
Thank you.
Great job, everybody.